Afternoon, ladies and gentlemen, and welcome to Lunch with Leaders. First, I'd like to tell you a little something about our organization. Leaders with Vision is a nonpartisan political organization to address the needs of all citizens to build a strong, more secure, inclusive, informed electorate, and to create a better quality of life for all citizens. We are an organization without borders. We will discuss topics from the international to the local level. Our mission is to serve as a catalyst for the community working solely or collaboratively with other organizations to build a better, inclusive, more informed society through civic involvement in all levels of society and government to address the needs of the citizens and, where necessary, to advocate and empower citizens to advocate for better government. And I think we've reached that crisis point right now. Our values are the recognition of the intrinsic worth and dignity of each person, worthy and need of a sound education in leading students to the truth, excellence in quality, hospitality, courage to innovate and the right to make mistakes, compassion, mercy, and justice, service to the poor, sick, and undereducated, response to need and respect for various religious traditions and beliefs. If you share in these ideas, please join us. And the application is at the registration table. Today's topic is healthcare reforms in Louisiana. We are particularly concerned, and I think that the level of attendance today points out that most Louisianans do not recognize that the healthcare reform will impact every citizen in Louisiana, either through your healthcare plan, through your hospital, where your doctor is going to be located, and who your doctor is going to be trained. It is a personal experience that leads me to share with you a story about my own sister, who is a graduate of the Charity Hospital system of education. She was a 3-year RN, graduated in 1958. She practiced for a while, and then as we all had children to rear and other things to do, she got away from her nursing profession. She moved after 25 years to Phoenix, Arizona, where nurses stand in line to get a job for a few days and retired, and it's a real mecca of retired people. And she was the 34th person to be interviewed for a few days' work at the local hospital. When she went into the room, they opened her folder and they said, "You are a graduate of Charity Hospital New Orleans?" And she said, "Yes, I am." She said, "We just have one question. When can you start?" And I think that tells you the level of training that we have had, luckily, in our medical profession. Today, we have lost that, and I'm sure that Calder Lunch, who is our first speaker, will address what he believes to be a good replacement for it. But I do say that when you have the finest training that medicine can get, it's going to be hard to replace it. Our speakers are here to address all aspects of how the reforms, the Medicaid expansion, affects citizens in Louisiana, and we will start first with Calder Lunch, the Louisiana Department of Health and Hospitals Policy Director. Calder?
Thank you so much, Ian. Thank you for this invitation to come speak to this group today. Calder Lynch, a little bit of type of speaking at lunch. But I am the policy director for the Department of Health and Hospitals, a role I recently took on. But I've been with DHH for almost 5 years now. It's certainly been a complex and interesting time for the state, particularly with regard to healthcare, and with our entire country as we move forward with the implementation of the Affordable Care Act next year. I want to touch on a few highlight issues. I've only got a few minutes, and then I'm really looking forward to the Q&A. Healthcare in Louisiana is a challenging issue. It has been for many years. I think we've got a very proud legacy with the charity hospital system, but it's difficult to maintain a separate tier of healthcare in a modern payment world, in a modern healthcare policy world. And over the last few years, our focus has really been on looking at, and coinciding with difficult budget times for sure, has been on looking at how do we design a healthcare system where we're getting better value for taxpayer dollars, where we're, as a government, as a payer, where we're purchasing our healthcare more effectively, and we're delivering higher quality healthcare for those dollars that we do spend. And I think one of the things that we recognize across the healthcare spectrum is that in many cases, government is better served as a payer of services or as an organizer of a market or as a quality benchmark, not necessarily being the direct delivery of healthcare services. I know we've worked over the last few years to downsize many of our large state institutions for people that serve people with developmental disabilities or people with mental health issues for two reasons. One, we've worked to try to integrate those folks into more inclusive community-based settings, as well as getting out of the long-term liabilities associated with operating very large, very complex, aging institutions. And so, over the last 5 years, we've gone from having 9 large state centers for developmental disabilities to having 1 that's operating today. And it's not that the people that were previously being served aren't receiving services. They're receiving services in community-based settings, in group homes, or in private facilities at a much, much lower cost to taxpayers. We're seeing something similar playing out today across the LSU system. We know that, and in fact, it was in 2005 that a healthcare group here in Louisiana issued a report kind of sounding the warning bells of the future of the public hospital system and how it wasn't keeping pace with the models that we were seeing across the country. I know Grady in Atlanta, other major large academic medical centers had divested of its government ownership or government control and had partnered with existing private health systems that could come in and focus on the actual running of the medical enterprise while these schools could focus on the academic portion, which is something we're doing here in Louisiana. Whenever we first signed the memorandum of agreement for the rebuilding of Big Charity in New Orleans, it was recognized that we couldn't go back just to the old model. It had to be a partnership between the academic centers that are in New Orleans, Tulane, LSU, and the other schools, with a focus on having to get out from underneath the constraints of a government-run enterprise. We also recognized that a few years ago when we signed the Cooperative Endeavor Agreement with Our Lady of the Lake here in Baton Rouge, to move toward eventually having the lake providing many of those safety net services as well as the medical training services here related to the School of Medicine. Those plans as moving forward have been under discussion for many years. What happened in July, though, was that after the budget passed and after we had adjourned for our legislative session, we were dealt with an unexpected blow to our Medicaid funding formula where Congress actually reduced our current year budget by nearly $1 billion. I guess unluckily for the state, it occurred after we had adjourned, but luckily it occurred at the beginning of the fiscal year where we did have time to come in and come up with a plan to try to address that, but it did require very immediate action, acceleration of the transition here in Baton Rouge to the lake, as well as plans to move forward with the private partnerships throughout the rest of the LSU system. Certainly, these changes are not easy. They're difficult. They require planning, lots of discussions between all these parties that are happening every day, as they work toward trying to meet their deadlines at the end of the fiscal year. But I think what we saw on Monday was a successful transition to the lake here in Baton Rouge. They're seeing patients that would have otherwise gone to Earl K. Long. Those patients now have access to a much broader array of services than what was offered at the Earl K. Long, much newer facilities, much newer equipment.
We actually have brought several services back into our agency that were being privatized because we actually can do them more efficiently and more cost effectively. And so that's maybe in the wrong direction that you see a lot of things happening. But I'm determined to provide services for people who are in need of detox services or families who are in need of having a loved one being seen immediately. We've moved to walk-ins, so people come into our clinics every morning. They may have to wait a few hours to be seen before lunch, but we no longer have a 16-week waiting list. That's just not possible, and we've already seen the impact of the emergency rooms. I have almost no time, but I want you to know about two important things. There was something called the Mental Health Emergency Room that we opened almost 3 years ago at Earl K. Long Hospital. Each year they saw over 2,000 people in behavioral health crisis. They either came there on their own, police brought them, or because of the coroner, sheriff's deputies brought them there. We were able to save the state $10 million a year by doing rapid stabilizations and then returning these folks back to their homes or back to where they needed to be, as opposed to putting them into a hospital bed. It was very innovative. It's one of the best models in the whole state. It closed this Monday. And so now all of the hospitals will be working with me to try to identify how we're going to handle 2,000 people a year who are mentally in crisis, who may be dangerous, who are in a very bad way, who are going to be in the general population in emergency rooms. And so we'll be working as a community to find solution for that. The other thing that I wanted to mention is I'm working with the judges in this area, the warden and the sheriff. I'm looking for a jail diversion program for the mentally ill. Oftentimes our mentally ill citizens end up with misdemeanors, nonviolent. They end up in jail. They get separated from their medicine and from their treatment, and then we release them, which sets them up to get into more trouble. So those are the two projects that we're working on right now. And I've run out of time, but I'm going to say my word. Oh, okay. Okay. So anyway, so those are the two programs that I really want people in this community to know about that are very important, that will save taxpayer dollars and will make this community safer. We have judges that support it. We have law enforcement that support it. As far as healthcare reform, there are some good things. We are very glad that under the essential services under healthcare reform, that 30% of the people who currently have healthcare insurance, hopefully everyone in the room, will now have benefits that cover addiction treatment. And then 20% of the people who have insurance will now have coverage for mental health services. And that's very important. We don't want to wait until people end up in a crisis or law enforcement getting involved. So to be able to respond to that, really the country does not have enough providers. Capital Area, my agency, has now moved to just accepting people who have a very serious and persistent mental illness, to allowing people who have moderate mental illness and problems to come to us. So you don't need to wait till you're really, really sick to see us. We will be able to see you because we've changed our criteria. We'll continue to work for ways to decrease any kind of time that you may have to wait to see us. But we have a very good team of physicians. We have very good social workers and nurses, and we are recognized nationally for the work that we do here in Baton Rouge. And so I hope that by talking about mental illness, talking about substance abuse, all of you will be more knowledgeable. We have so many people in our community that need help that don't go because they're embarrassed or they're afraid that they'll be stigmatized in some way, that people won't want to have them around, they won't want to employ them, and guess what? They're all over the place. And so all of us, if we really care about folks that we live among in our community, we need to encourage people to get the help that they need. As long as my agency is here, we have a commitment, all of us. They said the fish stinks from the head down. I'm trying not to stink. I'm trying to stay really focused so that I can lead my people who do a really good job, an important job, to help the citizens in this community get the help early enough that they need, but also helping to deal with emergency services and really helping to keep people who are nonviolent offenders out of jail so that they can get the treatment they need and live.
And when his wife came home one Sunday, he didn't go to church. And when she arrived home, was sitting on the couch, he said, "I'm sick as I can be." They got the ambulance. And because you're putting everything out in the hospital corridor, you made the ambulance drivers disobey their arrangement, because another ambulance was in front of them, and it caused that patient's wife to indicate what was happening, get my husband to the hospital. And so the driver called ahead and asked him, "Well, can you swap with me? This is more, this is a greater emergency than I believe you have up there. What do you have?" And they compensate. He said, "Come on by." And that was got Percy to the hospital in time to save him, because something had broken loose that had been when he had had surgery, and he was bleeding to death inside. We don't have any service up there. And yet everything was taken from us. And the very few beds that we have up in North Baton Rouge, does not accommodate all the surrounding area of people who was going to Hurricane Loma, especially in times of emergency.
Okay, Calder, would you respond to this, to the lady?
Absolutely. I'm sorry, I don't know the specifics of that incident. I'm happy to, to discuss that with you. I think, though, that anytime someone's having an emergency, they're going to be taken to the nearest hospital, regardless. Sure. But and with regard to trauma services, one of the things that we will have, as part of the agreement with the lake that we did not have in Baton Rouge before, is a level 1 trauma center. They were level 2 before. OK Long really wasn't equipped to deal with large trauma cases. So we will have that additional capability. But anytime someone's having an emergency condition, they're going to be brought to the nearest hospital facility. That's always
The traffic. Have you ever been in the traffic to head north?
I have been in Baton Rouge traffic. Yes, ma'am. Certainly, those are transportation issues that will continue to be worked out. But I think that there are opportunities for individuals to access enhanced services here that they didn't have before. I think that if someone's in North Baton Rouge, they're going to be taken to the nearest facility, and there are methods through our uncompensated care program that we can pay for services for individuals that are uninsured. We at any hospital that's nonprofit or quasi-governmental through a hospital service district has, through their nonprofit status, an obligation to see a certain amount of uncompensated care, and we have mechanisms through our disproportionate share hospital program to pay for those services. So it's not really a different situation than what existed before. I think this is a problem that exists in every community across the country.
But doesn't that go away when we reduce the Medicaid, that uncompensated care?
We currently use less than half of our annual dish allotment, and the president's budget has already announced their intention to delay those reductions for another year. So there could be, in the next few years, as much as half of that funding reduced, and we wouldn't see an impact on our ability to pay for the services.
Could this administration, in their planning for North Baton Rouge, consider putting a trauma center in North Baton Rouge to support the citizens that live up there?
We currently only have a few trauma centers in our state. There's one in New Orleans, obviously, with the interim hospital there. There's one in Shreveport's level 1 with the LSU hospital there. OK Long will only, Arley the Lake will only be the third level 1 or 2 trauma center in the state. So they're not very common, as far as the catchment areas are concerned. So I think having one in centrally located Baton Rouge serves the entire community.
This gentleman over here has a question.
Yesterday we saw that.
You have to stand up.
The LSU board. Yesterday we saw that the LSU board approved partnerships for private companies to manage their facilities. This is the same week that the House and the Senate both passed resolutions saying that they wanted that sort of agreement to come before them for approval. I want to get everybody's take on that, whether or not those sort of agreements should be subject to legislative approval.
Okay, the question is, should public-private partnerships under the LSU system be approved, require legislative approval? Let's shake things up a little bit. For someone who's been there, we're going to start on the other end. Pick on David. David, we're going to start with you. Should it require legislative approval, this use of public-private partnerships?
Well, I think it definitely should require legislative approval. I hate to say this, but this administration has acted like as if they're the only branch of government. The legislature is often left out of the loop on whatever they're planning or whatever they're doing. My understanding was that it did require legislative approval, but the Attorney General ruled, I think, just last week that no, it doesn't. You can go ahead and proceed without the legislature. I think that's a bad idea. If that is what the law says, then I think the law should be changed. And the legislature should be in the loop on just about everything. It doesn't make any sense to me. They have to put up the money to fund all these hospitals and these partnerships and so on. And to me, it makes no sense that they don't have a say-so in this matter report comes to them, and they have to fund it.
Jan, you know anything to comment? Chris? Okay. Chris? You agree? Okay.
First, I want to say that we've had legislative involvement throughout this entire process, dating back to the first agreement with the lake in 2009. We were engaged with the Baton Rouge area delegation. They've been included in these discussions. They've been included in every single community across the state where we've met with legislative delegation, with local hospital leaders, with LSU leaders. The law clearly does say that anytime we close an LSU hospital, it does require legislative approval. And we did that in 2009 with the first cooperative endeavor agreement. We did it again last week when we amended that CEA to move up the transition date for OK Long. It moved out of joint budget unanimously with no opposition. The Attorney General has said that anytime that a hospital is just simply taken over by private management, that does not require legislative approval. But we've been very clear. The CEAs have been put online as they've been approved by the Board of Supervisors, and we've been engaged with legislative leadership and local delegations as we move through this process. And we'll continue to follow the law.
Christina. I understand that we failed to notify Meditech or CMS of our intention to close these hospitals, and that we have some huge financial implications from that. What's the situation for that?
That's a good question, and I do want to point out that the only hospital closure that's on the table is OK Long, as Our Lady of the Lake, the services move there. The rest, the hospitals will remain open just under new management. There are routine state plan amendments that we have to file with CMS with regard to payment methodologies for services. We do hundreds of these a year with regard to variations in our state plan. It's a process where we go back and forth with questions. We routinely begin operations on a new state plan before we reach final approval. So far, we've not received any indications or questions that are outside of the normal. Some of those concerns date back to the original plans of actually having the local clinics provider-based. All clinics have to be provider-based. We're going to have them to the hospital in Lafayette. CMS had some concerns with the mileage distance, and the actual referral pattern of patients wasn't going to match those designations. With the new cooperative endeavor agreement that was amended, those clinics are going to be provider-based to Our Lady of the Lake, and that is a routine attestation that we file with the federal government that becomes effective as soon as it's filed. So there's no concern there.
We don't have any big amount of money to have to pay back because we didn't do that.
We have no concern on the front.
On the transparency issue, I'm sure that you do meet with legislative leadership, you meet with committee chairs, you meet obviously with the entities that will be engaged in this, such as the LSU partnership. But what I think what people are looking for is let's have an open discussion that the public is invited to, namely. Why not bring it to a legislative committee so that it can be discussed there? One of the things that I've recommended over and over again is why not have a health reform commission that would be made up from legislators, from consumers, from providers, and other officials around the state, and they would come in on a regular basis, hold public meetings, and allow the administration to come and talk about what they're doing, so that the public can get involved as well. I think all too often we just don't know what's going on. There have been a lot of complaints, even from legislators, that they don't know what in the world y'all are doing. So I think that's a big disappointment for me, but I think that can be changed. It's not too late. It's never too late.
Well, I think that everybody has been disappointed that Governor Jindal ran on transparency and ethics, that he was going to make that the gold standard, was his language, and frankly, his performance on the fourth floor as far as transparency has not lived up to accomplish it. Howard?
Okay, I have to concern here real quickly. It was stated that, supposedly the majority of services that were formerly taken care of, okay, law, could be held at the urgent care clinic. And so it's not a real big deal that we're putting everything back down here on SLA. But my problem with that is that even if that's true, if your case happens to be one of the cases that doesn't fall in that category, it's not comforting to that family. Okay? That the majority of cases could have been handled at the urgent care clinic. Because we still have an access problem. Now, again, I mean, maybe I'm not the wrong person because the governor is the one who's driving this. But it's no comfort to the people in North Baton Rouge, your argument that the majority of cases could be handled. Because if your case is not in that majority, that's life and death for you and your family.
What's your question, Albert?
It's not a question, it's a comment.
All right, Ted.
It's my understanding that the federal government will set up exchanges for the states that have elected not to do it. I'd like to know why Louisiana's not doing it. Is there an advantage to having the federal government set up our exchange?
Louisiana has opted for the federally facilitated exchange, and we made that determination pretty early in the process as we saw the regulations that were being issued by CMS really didn't leave a lot of flexibility for the states with regard to how the exchange would be structured. We were also concerned with some of the technical complexity and remaining unknowns with accepting that risk on the front end. Even today, I think you saw last week, Democrats in the U.S. Senate were expressing a lot of frustration over still not having seen work plans, not having seen the contracts that are building a lot of the technical components that go behind the scenes in this exchange. And Louisiana is now actually one of 26 states that have opted for the full federally facilitated exchange. So there's still a lot of unknowns as we approach now less than 6 months away from when open enrollment is supposed to begin. So for us, we know that in 2015 these exchanges have to be self-sustaining, which means we would have to generate some form of revenue source here in the state to pay for that if we were to opt to build our own. It was more prudent to allow the federal government to take that responsibility. And that's a decision that can be revisited at any point. But at this point, we still don't have assurances. We still don't have enough information to have comfort in what would have to be done to actually create and have a functional exchange on the timelines that they've set forth.
I believe that's the first time I ever heard anybody in the state say they think the federal government can do it better.
I'm not saying that I think we can do it better. I'm saying that we don't have enough comfort to know that we can do it without putting our own taxpayers at risk.
Well, I guess my question is why didn't we go another route? What I would like to know is why didn't we have there is a third possibility. We could have done a partnership with the federal government so that our people would be involved on a day-to-day basis with setting up the exchange. Feds would be there to help direct us and so on. And if in the future we wanted to take over the exchange, then we could do that. There are provisions in federal law that allows that to happen. So I think that would have been a better idea. I mean, I kind of understand that we don't have experience in that. It might be expensive, it might be this, it might be that, but the partnership, which some states have followed, half a dozen, 10 states, I think, would have been a preferable path to follow, I think. Also, I've often wondered why the Department of Insurance is not the entity that's involved in this, because that's the people that they serve, basically, the people who will use these exchanges. And they were at first, until one of them said something like, well, we think this is a good idea, and with setting it up. And I think the next day, he was relieved of duty, and the whole thing went over to the governor. Well, he's the governor, he has the authority to do such a thing, but I wonder if that was such a good idea.
You bring up a good point on the partnership exchanges, which was not something that was contemplated in the original law, but came later as CMS was seeing the volume of states that were opting not to participate. There are a few different approaches the state could take to a partnership exchange, a few different functions that they could potentially take on, one being consumer assistance, the other being health plan management, where they would actually review the plans to determine that they meet federal requirements under the new regulations. Essentially, though, what we saw in the guidance was that there was sort of a predetermined set of responsibilities that the state would have to take on. I kind of liken it to a franchise in that you might be the individual owner of that McDonald's, but you're still having to use the McDonald's meat, you're still having to use the McDonald's burger, you're still having to use the McDonald's recipes and follow all of their policies. So it wasn't something that was particularly interesting with regard to having some additional flexibility. But I will say that we continue to be very engaged with CMS. We're on very regular conference calls with them. We participated in all national conferences and meetings. We ask questions, we comment on all the regulations that come out. So we're fully engaged in the process, and we're watching. And we do work very closely with the Department of Insurance on those fronts. We have a weekly meeting with them to discuss these issues. And so they're engaged as well on all these, on everything related to health insurance exchanges.
But we're not.
Well, certainly, I think any individual can comment on the regs that come out from the federal government. From our state's perspective, we're listening, we're participating, we're watching. But as we're not actually actively building the exchange, we are staying informed of those developments so that we can be ready on any things we have to do on our end. For example, in Medicaid, we have to make some adjustments to the way we determine eligibility to be compliant with the law. So our teams are working on that now to ensure that we're ready. We want to ensure that, whatever responsibilities we have, we're prepared for. And as we look at what's coming down, we're just uncertain whether the federal government will be prepared.
And you understand that as providers of health care, we're in the same position you are.
Absolutely.
We want to stay informed of what's going to be expected of us.
Information. We're worried that that's going to lead to a significant amount of market disruption this fall with the launch of the exchanges. There's still just a lot of unknowns. We ask repeatedly for details with regard to federal work plans, contracts that they've executed to build some of the services that go behind the exchange, the federal data hub, and we really haven't received much information.
One last question, and then because we promised these people they could go by 1:15. You have the last question.
Thank you, I appreciate it. I want to ask a question along the lines of what I think is the elephant in the room, the Medicaid expansion, and I don't want to get too deep in this because I have personal involvement in it. But recently, the PHA released a report saying that there was a reevaluation of cost savings that might be associated with the expansion. I was wondering if you could elaborate to that. And also, I know Arkansas has put forth a proposal of a model whereby they would do something different with the exchange, possibly funneling some of the money into a private concept. And finally, and this is critical because I cannot get any information on this from anyone. Several months ago, New Orleans had put forth a proposal where they could possibly go into expansion alone. The administration didn't really shoot it down. They seemed somewhat receptive to it, but since that time, we've never gotten any further details about it, and I was just curious as to where it stands.
I'm going to try to address this really quickly. I'm sorry, we're talking all the time. The first question with regard to the expansion, I think that one of the key issues here that has to be talked about is when we talk about Medicaid expansion, depending on whose report you look at, because there's certainly a great deal of uncertainty and unknowns and assumptions that have to be made in making an estimate of what the impact will be. We see anywhere from 450 to 650,000 individuals would end up enrolling in Medicaid as a result. When we look at the actual uninsured population in the state today, we know there, according to our best data, there's about 653,000 uninsured individuals. The vast majority of those being adults, 633,000. If you break it down by income levels, there are about 274,000 individuals of those that are going to become eligible for subsidized coverage in the exchange. There's about another 67,000 individuals that are above 400% of federal poverty level. So they're outside of sort of that safety net catchment area. There are only about there's about 77,000 individuals individuals that have incomes between 100 and 138% of the federal poverty level, that because of our decision not to expand, actually become eligible for the heavily subsidized coverage on the exchange. So there's only actually about 214,000 uninsured adults in the state that really are the focus of our safety net population. So when we talk about expanding Medicaid and the costs associated with it, it's a much larger sort of policy to address the needs of a smaller group, which is one of our main concerns. The second being the costs associated with it. I think, as Dion talked about, there's a concern with regard to provider rates. I mean, we're sort of holding the system together with ball and string today, but by adding another as much as 500,000 or more individuals into it, you're going to probably have to increase provider rates in order to maintain minimum access. And we already know that the law actually puts a new standard on states to ensure the provision of healthcare services that could result in legal action against states that require them to raise their rates. So when we look at the analysis of expanding the program, we've got to take into account what that cost could be, and it could reach the billions over 10 years. And that's why we talk about the expansion costing the state as much as $1.7 billion in the first 10 years in new state tax dollars that we have to commit to. The report was updated a few months ago. It removed some of the early assumptions that we know aren't accurate anymore. It adjusted some of the take-up rates. It included reductions in dish spending as a result of expanding Medicaid, as well as it included new cost savings as a result of the implementation of Value Health. And it presented a very wide range based on those things I just talked about of what that potential impact could be. And finally, your question about the Arkansas model, we've watched that very closely. Unfortunately, a few weeks ago, CMS released additional guidance in the form of a frequently asked question document that really showed us that there was not going to be a great deal of additional flexibility over current law with regard to providing premium assistance to individuals who are enrolled in Medicaid. Anytime you provide premium assistance, you're still required to provide wraparound benefits. Medicaid offers a benefit package that is much richer. It includes things that aren't necessarily included in the federal essential health benefits package, like transportation, non-emergency transportation, APSDT requirements for children under 21. So there's costs associated with providing those wraparound benefits to those individuals. It requires that you do additional subsidy to reduce their cost sharing to the level that they would see in Medicaid, and it would require a waiver. And they said they're only going to grant a limited number of waivers. So based on the administrative complexity of administering a program and not having the flexibility around cost sharing and around the benefit package, it really isn't a viable option to move forward with.
And the New Orleans proposal.
Oh, the New Orleans proposal. Yeah, I remember that discussion, and I think that's been discussed in a few other parts of the country. Under federal law, we have something called single state agency that requires that the Medicaid program be governed and administered by one single state agency. So there really is not a way to break off and do something in an individual municipality. And federal guidance has said that they aren't considering any partial or phased in expansions of Medicaid. It's got to be all or nothing.
Well, I've got a question.
Sure.
The governor has said that he doesn't want to,
David, you have come here, so we pick it up on the video.
the governor has said that he doesn't want to expand Medicaid and have 400,000 new people come into the program because the Medicaid program is basically broken. It just can't handle it properly or whatever. Well, what I want to know is they would all go into Value Health, as far as I know, which is your program. That was your health reform program. So what's wrong with it now? Because that's where all these 400,000 people will go.
That's a great question, and we are very proud of Value Health and what it's doing in the state today. I think it's important to remember when you look at our Medicaid program today, particularly those that are enrolled in Value Health, the vast majority of children. And so when those plans, are designed with the benefits are designed, with the provider networks are designed, it's designed around those needs. When you add an additional as much as 500,000, mostly uninsured adults who are going to demand a different level of services, the system there, the benefit package is not going to be able to handle that influence. And our concern is that you're going to have, over time, a very large increase in the need for state funding as if the state has to increase provider rates. We're going to see, we've already seen since 1997, the percentage of our state general fund that are consumed by the Medicaid program more than double, from 12 to 26%. And so it's just simply not sustainable for our state to to continue to expand the entitlement program, and eventually what we would see is over half of our state, when you include Medicare, in some form of government funded and run healthcare system. And when you start having more people in the cart than pulling it, it becomes a difficult sustainability issue. We think there's a smarter approach to provide for the more limited population that we see as being continued safety net need.
Don't move, Colin. We still have people out there, so what do we do with the people that aren't being covered?
We do, and there are certainly unmet needs, and what we're working on trying to do is create a more organized safety net system where we're able to spend our dollars more wisely. We know that giving someone a Medicaid card doesn't necessarily even guarantee them access to services. So we're looking at across the LSU system with public-private partnerships, trying to provide for more access to the care that's needed in a way that's more sustainable for our state. I think there's continued discussions around that issue, but just putting them into the traditional Medicaid program isn't the solution.
But you said a few minutes ago, EPSDT for children, which ties our hands, we have to provide whatever it is they need. But then you're saying, if we put the adults in it, which we don't have to provide everything they need, then it causes more problems. But I don't know.
EPSDT is an example of something in the Medicaid benefit package that we don't see outside, but there are other things like non-emergent medical transportation. And really the cost sharing issue is a concern because you have to provide some mechanism for the state to make additional subsidy contribution to that coverage. And that just becomes administratively burdensome to run, and ultimately probably more expensive than a traditional Medicaid program because the rates that the paid providers are going to be higher.
Thank you very much for coming, and next month, third Thursday, we'll have another exciting topic to be announced. And just remember, Colin, please take that to the governor, that the people want transparency, okay, and accountability. And only through transparency will we get the accountability. Thank you all for coming, and we'll see you next month.